All right, welcome to UMDcast episode 7. Today we'll be interviewing Dr. David Berger, the new CEO named for the University of Brooklyn. Thank you, Dr. Berger, for taking the time to speak with us this afternoon.
My pleasure. Looking forward to the conversation.
Amazing. So we would like to begin by asking you to give us a brief summary of your academic background or path leading up to your current position.
Sure. So I don't want to bore everyone, but I went to undergrad at SUNY Binghamton, did my medical school at SUNY Downstate, and I completed a surgical resident at SUNY Downstate. I did 7 years. I did 2 years of research as part of my residency because I thought I was going to be an academic surgeon. After my surgical residency, I completed a 3-year fellowship in surgical oncology at MD Anderson in Houston, and then set out on my academic career. My first academic job was in Philly at what was MCP Hahnemann, became Allegheny, and is now Drexel University Medical School. I spent 5 years there and then was recruited back to Houston in 1999. Someone who I was a surgical resident with became the chair of surgery at Baylor College of Medicine, and he recruited me to Baylor. At Baylor, initially I was the operative care line executive at the Houston VA, which is now the Michael E. DeBakey VA, which is actually the largest VA hospital and most complex in the entire VA system. I was also an associate professor of surgery and then became a full professor of surgery during my tenure there. Initially, I was, as I mentioned, in academic surgery. I had a surgeon, I had a basic science lab, and then changed my research focus to outcomes research. I had both of those programs funded by federal grants. But as I progressed in my career running the operative care line at the Houston VA, I really became interested in leadership as well as management and pursued a degree in healthcare management. I have a master's in healthcare management from the Chan School of Public Health at Harvard. And because of the success we had at the Houston VA, I then was recruited over to the private side and became the chief medical officer, then the chief clinical officer, and the chief operating officer at Baylor St. Luke's Medical Center, which is the main teaching affiliate of Baylor College of Medicine. And last year, I was recruited back to my alma mater to be the CEO of University Hospital of Brooklyn. I'm also a tenured professor of surgery and also a tenured professor in the School of Public Health at Downstate as well.
Wow, that is quite the journey that you had there. So what exactly was it that really turned that was like the realizing moment that you realized that you really wanted to go into healthcare management rather than continue on in academia for most of your career?
So I think all through my career, so if you go back, why be a doctor, why be a surgeon, why go into academics, it's all about mentorship. And that is one of the most important things I think young people going into any career, not just medicine, need to think about is who are your mentors now and who are you going to develop mentoring relationships with over the course of your career. So I became an academic surgeon because on my surgery rotation, I really loved working with an attending who was a surgeon. He was a chair of surgery at Harvard, and I really wanted to be like him, be an academic surgeon and potentially a chair one day. I became a surgical oncologist because during my surgical residency, I had a great mentor. She was a surgical oncologist and she took me under her wing, and I really enjoyed oncology, so I became a surgical oncologist. Then during my academic career, my leadership career, I started gravitating to other people who were leaders in healthcare, as well as people who ran institutions like hospitals, healthcare organizations. And I realized that was something I really enjoyed and wanted to do. So I think career path has is really influenced by who your mentors are. And then the other thing I love about being a doctor and doing what I've done throughout my career is I love getting up in the morning and going to work. I think that's really different in medicine than in a lot of other careers. You could either be passionate about what you do at work, or you could work to accomplish your passion outside of work. And either way works. But I think the reason I love medicine and I encourage people to become physicians is medicine is so varied, right? I was an academic surgeon to start with. Then I was a leader in academic surgery, and finally moved on to running hospitals. So the amount of flexibility in your career is really unlimited. You can do anything you want. So I think medicine is an incredible career, but the important thing is identifying mentors. And not everyone feels comfortable with developing those relationships. But the important thing to remember is mentors love mentoring young people. There's nothing more rewarding to me than to helping someone pursue a career path similar to what I had. So you shouldn't feel uncomfortable approaching senior people and say, look, I'm really interested in medicine. I'm interested in what you do. Tell me about why you became a physician, why you're doing what you're doing. And can we continue this conversation and have an ongoing conversation going further and then forward? And then if you have questions or you have issues, like you're going to take your MCATs, you're going to apply to medical school, it's important to ask your mentors about their experience. What do they think about your personal statements? What does your resume look like? To get input. And people are really generous with their time in terms of helping to mentor young people. So I can't say enough about how important it is to develop a mentoring network.
So what would you say are some characteristics of a mentor that you should look for? Like, how do you find the right mentor for yourself? And like, what are maybe some features that you should be looking for?
So I think it's important, one, to identify someone that you admire, and that could be for any reason you have. And the mentor doesn't need to be the CEO of the hospital, right? So you can have a wide mentoring network. It could be peers, it could be people close to your age who've already gone through the process. Mentorship is really wide, and I would say it's important to meet mentors and identify mentors who are going to be generous with their time and are ethical, right? You don't want someone who's going to say, well, I cheated on my MCATs, and here's how you could cheat on your MCATs to get a good score, which is really what's important, to get a good score. You want to make sure people have aligned with you what your ethics are, but also are going to be generous with their time. And it's very important to have a wide breadth of mentors. We talk about a lot about diversity, equity, inclusion. I would say it's important to have a wide breadth, a diverse group of mentors, and don't shy away from certain groups because you're uncomfortable talking to them, because they provide a different perspective on things that are going to be important during your career. So diversity is key. People who are generous with their time, and make sure that they're ethical and their ethics align with you as a person.
So shifting a little bit, but what would you say is one thing that you miss most about being a physician that sees patients every day, as opposed to now being a CEO of a hospital? I'm assuming that's either a lot less or close to none.
So that's a really great question. And why did I go into surgery? I went into surgery because I loved being able to meet a patient, identify a clinical problem, and work with them to solve the problem. Surgery is a field with immediate gratification, right? So if you're a surgeon, someone comes with appendicitis, you diagnose the appendicitis, you take them to the OR, you do a nice little operation, and they get better and they go home. It's incredibly gratifying. So the things that I miss most are, one is that, but two, the interactions with people. Surgeons meet people when they're at their most vulnerable, right? And it really, you have to think about and relate to the person as a clinician, but you're also potentially dealing with a life-threatening emergency and a life-threatening problem. So I remember vividly, I was on call. I get called by my resident when I was at the VA at 3 o'clock in the morning, telling me that they had a patient with an abdominal catastrophe. Basically, they had a huge amount of their intestines appeared on the CAT scan to be dead and necrotic. And the patient was in his late 40s, early 50s. And the conversation I had with him was that you have a really, really bad problem, and there's a possibility you may not make it through this operation. That's a difficult conversation to have. But the patient said to me, "Doc, I trust you. You need to do whatever you need to do. And if this is my time, this is my time." And, you know, we spent a couple of minutes praying together that this wasn't his time. I took him to the operating room, and he had probably 7/8 of his small intestine was dead. And if it wasn't such a young person, I probably would have just closed, and that would have been the end. But I took it all out because he was so young, and he made it. He did well. You know, he had issues with digestion and vitamin loss and a lot of things like that. But I saw him every 3 months for the next 6 years. And the thing he said to me was, "Doc, remember that conversation we had before we went to the operating room?" And I said, "Yeah, I remember." He said, "Well, I am so grateful that we had that conversation and that I'm still here, and thank you for that, Doc." So that's what I miss.
So with that in mind, would you say that there's any aspect of management that you would say exactly mirrors or resembles the gratification of patient interactions such as that? Or is it in a different way that you feel gratification?
So it's in a different way. So the thing I loved about surgery was that one-on-one, being able to really influence the life of one patient at a time. Running an organization, you have the ability to have an impact on lots of thousands of patients by delivering outstanding care, right patient, right place, right time. And also you have a tremendous opportunity to make a difference in the lives of your staff. Right, so my belief about running a hospital organization is the first thing is you need to have employees that are happy and engaged. Because if you don't have employees that are happy and engaged, they won't go the extra mile for their patients. So I have the opportunity at 3,000 employees to impact the lives of 3,000 employees, and then 12 to 20,000 patients that get admitted to the hospital, and another 100,000 patients that come through our clinics. So it's not the one-to-one, but it's the ability to really change how care is delivered to a large group. So you magnify the impact that you have.
To kind of change the conversation a little bit, I was curious about what your role as CEO of the University of Brooklyn is. Like, what are your daily duties? What's a day in the life of a CEO kind of like?
So I still keep surgeon's hours. So I'm usually here by 6 o'clock in the morning. And my most productive time is 6 to 8. So what I try to do is I try to answer all the emails that are pending, any presentations that I need to give, any information I need to collate goes into that 2 hours. Then a lot of the rest of the day is spent in different meetings. When you get to this level, you don't tell people what to do. You work together to decide what they need to do. So most of my day is spent with people, setting the agenda, helping them get through their barriers, and then helping them to monitor their progress. But my job is to work through others, not so much that I have to do everything, but I monitor what's going on. I help set the vision, and then I work with people to help direct them and achieve what they need to do within their scope. So I spend a lot of time in meetings, but I also spend a lot of time walking around the hospital, meeting staff, meeting patients, trying to see actually what goes on and how care is delivered. So in addition to the meetings, spend a lot of time walking around, and there's the issue of management by walking around, and that's a lot of what I do. So CEO is not a manager. I have managers. CEO is the leader, and the leader is the one who helps to set the agenda and to focus people on what needs to be accomplished.
I guess I just had a question. As the role of like that leader, is there anything you do to kind of keep like the morale up in the hospital, or like keep people more happy, just because, you know, sometimes, as you were saying, like the news isn't the best. So I was just wondering if there was anything you do for that.
So a huge part of what I do is employee engagement. So, you know, I have 5 things that I look at from the 60,000 foot level as the CEO. Number 1 is employee engagement. And as I mentioned, if you don't have happy workers, you don't have happy patients, you don't have good outcomes. So we spend a lot of time. So a couple of things that I do besides walking around is, when I first came on, and I still do this with different groups within the hospital, I have what's called bagels with burger. So I'll go to a specific unit, I'll bring breakfast, and we'll just talk about what's going on in that unit, what their challenges are, and you know, what I'm seeing in the hospital, and the direction I think we need to take. So that's with all the staff. The other thing I do is I have frequent focus groups. So I'll take a group of people, these frontline staff managers from different areas. We'll go in a room and we'll talk about what's going on. So my first round of focus groups, I asked people 2 questions. I asked them, why do you work here? And why do we exist? And there's a great TED talk by Simon Sinek about successful organizations and the why. So I wanted to know why, because I really think the mission, the vision, and the core values need to be based on why the place exists. The second time I did the focus groups with the same people, I asked 2 questions. Tell me one thing that's going well. tell me one thing that's not going well. And those questions are just to facilitate conversation. So Bagels with Berger, focus groups. Last week we do a lot about wellness, especially now with COVID. So we have a wellness site on our website with different YouTube videos that we've posted about different aspects of wellness, exercise, diet, activity, all kinds of ways to lead a healthy life, mental health as well. We have a room that we call the the relaxation room, where people can go. It's nicely decorated. There's video, there's artwork on the wall with calm lights, and just chill out for 15 minutes, half an hour. We put in place virtual mental health and psychiatric and psychological consultation for our staff. Last week we had hospital week. We had a talent show. We had walking the red carpet. We handed out ice cream. I was here midnight to 1 a.m. handing out ice cream to the night shift. So we spend a lot of time on employee engagement, employee satisfaction, and trying to make this the best place to come to work.
That sounds like a fantastic work environment that you're facilitating. So kind of back to some of the improvements around the hospital regarding patient care and all of that. So what are some examples of some of the implementations that you have put in? Like I had seen that you had raised the leapfrog safety score from a D to an A. So what were some of the things that were involved in doing that?
So you guys can look this up after. There's a very, very famous person in health outcomes by the name of Downstate. And he has a very simple model about outcomes. So structure is first. Then after you put structure in place, process. And if you have strong structure and process, you'll have great outcomes. So coming into a new organization, and there's a couple of really good books on this, the first 90 days and good to great. The first thing you do when you're coming into a new organization is you have to assess your team, whether their strengths and weaknesses, who is on board and who's not on board. And if you look at good to great, it talks about getting the right people on the bus. So always the first thing is evaluating your people. You don't want to get rid of people, but you need to identify the people and who are the strong performers and who are the people that are going to come around, and then make sure you have those right people. Once you have those right people and you build the right structure, then you create the processes. And if your processes are good, your outcomes will be good. So how do you get from a low performing organization to a high performing organization in healthcare? Well, there's really, and rather than talk about how the specifics of getting from a leapfrog D to an A, there's 3 core processes that have to work in any healthcare organization in order to make sure you're taking good care of patients. And the first one is making sure that you identify the patient correctly, that you have robust process around patient identification. And it may seem simple, but you're giving meds, you're taking patients to x-ray, you're doing procedures. And if you read the news, you'll see that there are errors in all of these places. So the first thing to do is put in a robust system that you can accurately, 100% of the time, identify the correct patient. That's one. The second process to put in place is a robust process around transporting patients in any healthcare institution. So patients move around. They move from an emergency department to x-ray to a unit to an ICU. And you need to make sure whenever they're transported in a safe manner. And then the third thing is handing off from one place to the next, so that each caretaker knows exactly what's going on with that patient at all times. And when you think about a hospital, every time there's a change of shift, there's a new nurse, there's potentially a new doctor. You need to make sure that the information from one caregiver to the next caregiver is handed off in a manner so that all the information is communicated effectively. So those are three key processes. You have people in place, and then you start working on the processes, and those are three fundamental processes. There's a lot more to do, but really, those are the things you need to do. And then in any organization, and you'll read this over and over, is changing the culture. You want to change the culture from being whatever it was. So if you're a leapfrog D, that means you're a low performing organization into a high performing organization. And in healthcare, how do you change a culture? I have found the best way to change a culture is around quality and patient safety. No one can tell you they don't want high quality and safe patients. You won't get resistance around that. So when you're going to move a culture in healthcare, it's usually around improving the culture and the patient safety.
So I had a very similar question to Sam. I also read that University Hospital of Brooklyn also was one of the top hospitals that avoids overusing unnecessary tests and procedures. So I was curious, it might be part of the different procedures you just mentioned, but how are your diagnoses, I don't even know, so accurate without the overuse of testing and procedures?
So studies have shown that the more tests you do does not necessarily contribute to making a better diagnosis. It's making sure you do the right tests for the right patient at the right time. And the way you do that is you have treatment protocols in place, and you monitor the use of specific testing. So, for example, doing MRIs for back pain. That's a huge place where there's overuse. Doing cardiac stress testing in patients that are low risk for MI. And there's a whole list of procedures that are overused. And the issue is protocols around those specific disease presentations, and also education for providers so they understand what is the proper testing based on a patient's presentation. And then you need to monitor to make sure that there isn't overuse of specific testing. And we're not perfect, but we're moving in the right direction on that.
So kind of moving on a little bit, but as the CEO of a hospital, as a part of your job, do you keep up with the latest and newest technologies in medicine? And then how do you decide when it would be a good opportunity to buy one of them or not implement one of them in your hospital?
So I love tech. I've spent a lot of time when I was at Texas Medical Center in innovation and evaluating innovation. It's important to understand healthcare is a digital business, right? With electronic health records and now virtual and telehealth, healthcare is a digital business. So it's really incumbent upon healthcare leaders to keep up with what's going on in the innovation space in healthcare. The problem is now that there is so much going on right now, is how do you separate the wheat from the chaff? And it's not easy. And the way I try to navigate the field is one that is I stay very up to date on multiple platforms. So I see what's going on, who's doing well, what's moving the needle. I attend meetings to see what the latest is. But when I evaluate a specific technology for my hospital, the things I look at is it solving a big problem? Right? And a big problem can mean a lot of different things. It can mean financial big problem, it can mean a patient quality and patient safety issue. There's a lot of different ways I look at what is a big problem. But there are so many different innovations, you can't look at all of them. So it has to solve a big problem. Second thing when I'm looking at it is I want to know who the team is that has developed the solution. And as a physician, I really want to see a clinician involved somewhere in the development team. If I decide that I'm still interested, the solution has to have a clear implementation path. And when I mean implementation, who's responsible for the implementation? And if you're implementing it, is the person who's going to be implementing it and staff in the front line going to have more work by implementing this or less work? And I'll give a simple example. When I was at the VA, I was implementing an OR workflow tool. The hospital was implementing what's called a bed management tool. So the OR workflow tool decreased the work of the people in the OR. The OR bed management tool increased the work of the nurses who were using it. The OR workflow management tool in 2 weeks completely deployed. Everyone was using it. And within a month, everyone said, we can't live without this. The bed management tool never was successful because it required the nursing staff to do more work in order to get the tool to work. So the implementation plan is really critical for any innovation. So it's big problem, who's the team, what's the implementation path going forward? And you can't implement everything because these things all cost a significant amount of money, but that's usually how I look at them.
With all these innovations in mind, so how much horizontal transfer of information is there between executives at hospitals and just hospitals in general when trying to share information? Or if they're kind of in the same area, is there any sort of competition, or is it always a collaboration within the medical community?
So within the hospital itself, anytime there's an initiative, there needs to be a communication plan. So the key part of change management is how you communicate the different aspects of the change. So you have to be very, very cognizant of communication. Successful organizations, and what I call highly reliable organizations, have two-way communication. So there's communication from the top down, but there's also reverse communication from frontline staff forward. So you can't run a successful organization if there's not open communication in both directions.
Yeah, I was talking about more like within like different hospitals themselves, like say like your workplace tool, like how quickly was that information told to other hospitals, and like when would they implement it and how soon would they get the knowledge on it?
Yeah, so there's hospitals are pretty siloed. Hospitals within systems usually communicate well, especially things that are successful. But once you are outside systems, the flow of information is not very strong.
And do you see this kind of as like a hindrance to the medical field as a whole that could really use improvement because like obviously the collaboration between everyone could be much more productive?
Yeah, so let's take the OR workflow tool. I would say there's at least 20 different OR workflow tools. There's 6,000 hospitals, and people, not everyone is doing the same thing and working to identify what's the best solution. There are some organizations that are trying to bring different systems together to test innovation in order to grow a platform. And I think that is really needed in order to really focus the innovation efforts. So it's so diffuse right now, but I think you're beginning to see some different organizations work together on innovation and trying to coordinate the pilot and research around it rather than just doing it one-off, but it is really discoordinated right now.
So I was curious about, I know you're more of like the leader CEO of the hospital, but I was curious how the dynamic of trying to be a successful hospital and patient care and like what the relationship of that dynamic is. And additionally, if it's ever come to like being a business versus patient care, if there's ever been any contradiction in that model.
Yeah, so there aren't a lot of physicians who run hospitals. I think it's probably around 15 to 20% of hospitals are run by physicians. I think what physicians bring to running a hospital is we understand the delivery of clinical care better. And while there's always issues around doing things and what the cost is going to be, I will never put patients and patient care at risk to save a buck. Patients will always come first and will always do the right thing for patients. I have the luxury of doing that because I'm in an academic medical center that's partially supported by the state of New York. That changes a little bit when you are at a for-profit institution that is beholden to shareholders, and you have to continually produce a positive bottom line. But I would say most people who run hospitals try to err on the side of doing what's right for patient care.
So I guess I just had one last question. I know you went back and got a degree in healthcare management. Would you recommend to students like us, our age, who are just starting on the medical track to combine it with business at all? Like, would you have gone back and done that yourself? Or would you say that it's not for everyone? It was more of like a going back type of thing?
I think it really depends on what you want to do with your career, right? So if you know early on when you're in medical school that you're really focused on the business of medicine, I would say it's not a bad idea to get a business degree as part of your medical school education, because it's easier when you're younger than when you're in the middle of your career. You have potentially a family, other financial issues to go back. The reason I did the program I did was because it fit into my schedule a lot better than some other programs. But if you know that you want to go into consulting, or you want to be a hospital CEO one day, then it's probably worth getting a degree, combined degree, when you're in medical school. Everyone doesn't need a master's degree in healthcare management or business to become a hospital CEO. It really depends on what you're exposed to and what your opportunities are as you are developing your career. So getting an advanced degree really depends on what else you're thinking of doing with your medical career. And it could be, if you want to go be a lawyer and then do JD, if you want to have do population health and spend a lot of time on population health and you like data analytics, and NPH is the way to go. So it really varies in terms of what you're seeing as your personal career path.
Okay, perfect. Thank you so much for your time. I think we all learned a lot from that. And we really appreciate that you took the time to sit down and talk with us.
Yeah, it's my pleasure. This is, I think this podcast is really important for people in your shoes who are looking for careers in medicine. I watched a few of them. I think they're all done very well and really paints a really positive picture of a medical career. And I do think, despite the bad press from some people, medicine is an incredibly rewarding career. You'll never get bored being a physician. It's a career where you're a lifelong learner, and there's so many different things you can do in medicine. So thanks for doing this, and I'm sure your audience appreciates your efforts.
Thank you for taking the time.
My pleasure.
Thank you very much, Dr. Berger.
Have a great day, guys.
You too. Bye.